Welcome to today's webinar. My name is Russ Rao, and I'm the Director of Marketing at Osteogenics. Before we get started, let me address how we'll be interacting today. We'd love to hear from you throughout the webinar and be able to answer any questions you may have. While we can't hear directly from you, there is a Q&A button on the right-hand side of your screen where you can type your questions at any time, and we will get them answered during the last 10 minutes of the webinar. Once the webinar is completed, it's important that you will find a feedback survey in your email. Please complete that survey, and once it's completed, you'll receive your CE certificate. So let me begin tonight's webinar by introducing our speaker. We're very fortunate and very appreciative that we have Dr. Steve Wallace with us tonight. Appreciate Dr. Wallace taking some time and spending the evening with us and sharing some of his valuable information. Dr. Wallace received his BS in Pharmacy and DDS degree from the University of North Carolina at Chapel Hill, where he served on the restorative faculty in the School of Dentistry. He then received his master's degree in Periodontics with honors from the Medical University of South Carolina. Dr. Wallace is a life member of the American Dental Association, International Congress of Oral Implantologists, a fellow of the American College of Dentists, and a life member of the American Academy of Periodontology. He has published original research in the Journal of Periodontology, the International Journal of Periodontics and Restorative Dentistry, and numerous other peer-reviewed journals. Dr. Wallace is visiting faculty member at the Medical University of South Carolina Division of Periodontics and the East Carolina University School of Dental Medicine. He presents lectures for professional groups, teaching institutions, and national and international professional meetings. With that, I'm going to turn it over to Dr. Wallace. Once again, thank you, Dr. Wallace, for being here with us.
You're welcome, Russ. I'm glad to be with you, and I'm pleased to share our work with all the attendees and Osteogenics as our sponsor, which we appreciate. So we're discussing tonight Peri-Implantitis. Why is it such a problem? Well, it comes from several things. Primarily, more implants are being placed. That's compounded by difficulty of diagnosis, and there's no accepted based protocol for treatment of peri-implantitis. If you ask 15 doctors, you'll get 15 different techniques. So it's sort of all over the place. Well, several years ago, we looked into the research and found that from 20% to 44% of implants develop peri-implantitis. Due to difficulty in diagnosis, many times this is not seen or found, so treatment is not instituted. Risk factors we should mention are, number one, smoking is huge, a history of perio disease, diabetes poorly controlled, alcohol, drug abuse, autoimmune disorders. Last but not least, inadequate plaque removal and control is the primary causative factor. You'll notice that in our presentation, the techniques and the research that we show is evidence-based. It's taken from published literature and accepted journals. So we'd like to discuss the surgical and prosthetic complications that affect peri-implantitis. So some of these are implant exposures can occur from the bucco-palatal implant position, number one, particularly in the anterior maxilla. Facial bone is very thin, very easy for the least little bit of exposure to occur in an aesthetic zone. And that turns into a real problem. And they can look like this. These are typical cases that I'm presenting that I have treated myself. All this is our own material. And as you can see here, this is anterior maxilla, threads exposed, rough surfaces present, bone has been lost, huge problem. Not necessarily always in the maxilla. This is an example shown of mandibular malposition allowing a dehiscence to occur due to lack of blood supply to thin facial tissue. So I'm giving you some of the aspects, the reasons that we see problems develop. Some are technique, Some are prosthetic, some are surgical. Exposed threads, for whatever reason, are a significant risk factor for peri-implantitis. This is research in June 2023 publication. Another huge factor in peri-implantitis is retained cement. Retained cement is like an atom bomb blowing up around an implant. It causes rapid breakdown, infection, and you can get an asymmetric bone loss problem that I'll discuss coming up. Case shown where we had the infection was due to retained cement, and it caused an erosion completely into the sinus. So I'm showing some of the cases that I've encountered in the last 15 years treating these kind of problems. Prosthetic case here, that's a problem. Abutment and implant gap was left. That caused bone loss, which turned into peri-implantitis. Prosthetically, you get crown overhang problems. Anything that interferes with adequate and thorough plaque removal is a potential cause of serious problems. And many times our prosthetic colleagues, laboratory technicians, will lean more toward aesthetic results than prosthetic ability to not cause plaque infections. So the two principles are not always in sync. Good case, inaccessible prosthetics technicians were attempting to create aesthetics where it was not going to be a very good result long term. These are some of the treatments that I've run across and I've observed in the literature: titanium brushes, plastics, glycine sprays, water jets, antibiotics, tetracycline, minocycline, doxycycline, Clorox, chlorhexidine. People use lasers, use titanium brushes and instruments also, peroxides. All these things are used by different practitioners, and we'll talk about why this is a transitional effect. Basically, it's long-term not effective. So what are published findings? We go to the literature. That's what we base what we do on, like most all of our colleagues do. So this is one literature result. Implant removal is recommended when bone loss reaches 1/2 the implant length. Well, if you go by this, there's going to be a lot of implants being taken out and replaced. Not what we want to have happen. Another publication about effectiveness. No clear treatment protocol with a predictable, favorable outcome. Well, unfortunately, that's still effective. That was published in 2017. Regenerative surgery. This publication stated that use of guided bone regeneration does not seem to be predictable in the treatment of peri-implantitis. So we're getting kind of a gloom and doom picture here from the published studies. So what we want to know is, how can we start replacing implants? Well, that's what the purpose of this webinar is going to be. We follow the science. It's out there. All we have to do is locate it, follow it, put it into practice. Number one, key evidence basis. Implantoplasty reduces the surface roughness of implants, inhibits biofilm without affecting biocompatibility of titanium. The last statement is very critical. Not many clinicians would agree with this, but it's published. You can have biocompatibility of titanium after removing the rough surfaces. Now, the implant companies don't want to hear that. That is not what they want to talk about. But this is published, and so that's what we go by. It was 2021, that's recent. Number two principle, regenerative procedure. That is the gold standard key. If you can regenerate vertical bone support for implants and stop infection, you've hit a home run. This study showed back in 2015, regenerative procedure was effective in the treatment of moderate to advanced peri-implantitis. So we're seeing now we've got some research that we can hang our hat on for principles. Number 3, this is a unique publication. It stated new osseointegration was seen to occur after peri-implantitis treatment. 2018, this was published. And this was a case where, this is a little gruesome, but this was a human autopsy case from Japan. A patient had been treated by regenerative procedures with bone grafting after preparation of implant surfaces, deceased. The doctor got permission for an autopsy specimen to be taken of his work, and this is the result from histology. So they showed, and that's one case, so obviously you can't make a generalized statement, but this showed that it can happen. Subsequent work has been shown that it is not once in a lifetime, but it happens regularly. So that brings us to what do I recommend and what do I do? What do we do? Peri-implantitis protocol. In a nutshell, it's 4 steps. Number 1, remove all threads. I've got an interruption on my screen here for some reason. Back to this. Here we are. Number 1 is remove all exposed threads. Remove all surface coatings. Graft with bone and biologic growth factors. Growth factors are the key to success in bone grafting around titanium, in my opinion. Plus, it's in the literature also. Last step, you place resorbable barriers. So this is basically the 4 steps. So carrying this out is a little more complicated, but that's exactly what we do with every case. We have a history of 15 years, approximately 1,200 cases treated, lost 11 implants total that we could not bail out and prevent from being lost. So that gives us a little bit more than a 99% success rate over a pretty long period of time. This is a typical example of one of our cases. This example shows a 9 millimeter vertical gain of bone around an implant with like 3 threads remaining. Now these are the kind of cases that we get. We don't get the piece of cake cases that have like 2 threads exposed. No, this is the kind of stuff we get. We have implants with 360 degrees of bone loss down to the last 3 threads. And those are the ones that we get to bail out. But you can do it, and you can do it consistently. The only key factor that you cannot overcome is mobility, which is not hard to figure that out. But if you have a case, no matter how bad it looks, if it's not mobile, you got a shot. You always got a good chance. So that's some of the criteria that we use clinically in our studies. This just shows a little table where we had 14 advanced cases that were preparing data for a future publication, showing vertical bone gain of approximately 7 millimeters in the worst cases that we had, 14 of them. So can vertical bone be regained around infected implants with peri-implantitis? Yes, it can. Is that consistent? Yes, it is. So why is this not being done by everybody? Well, there's a lot of reasons, hard to explain. Socio-economic factors. However, I'd like to get into one other topic before we get philosophical. In the aesthetic zone, this is even more important. When you have peri-implantitis in the anterior maxilla from 7 through 10, you got a major problem, because then no matter what you do surgically, you're going to have repercussions with shrinkage, soft tissue shrinkage, thin tissue, loss of bone support, just a whole plethora of problems that you're going to have to face. Not to mention replacement of an entire implant is going to be problematic, because then you have to deal with all those negative drawbacks with bone and soft tissue recreation, reconstruction. Not a fun day. So, with a case like shown on the screen, if this can be treated and we don't have to completely take this out and replace it, you're ahead of the game automatically. So, this type of treatment of peri-implantitis in the aesthetic zone is extremely valuable and saves us a ton of headaches. So I want to show you some details about how this particular case was done. This is a video showing that case being treated. And I'll go through and describe just typically what goes on. Full thickness incisions are made for full flap reflection. Most periodontists use split thickness techniques for lots of things, but in this case, that is not what we do, and that's not necessary. The main key that I'm looking for here is to have flap mobility for repositioning. If you get repositioning, and you'll see I've made this very wide at the base so as to be able to mobilize that tissue as much as possible and have a passive flap sutured into position. So there again, this is full thickness dissection. And once we get this dissected, and I'll describe as we go along, the implant surface is treated in such a way as to remove all threads. This is not titanium brush and cleaning and removing it. This is taking a long shank burr intentionally and removing every single thread, or 99% of the threads. That's what causes the peri-implantitis problem to begin with, and perpetuates it. So if you clean threads or rough surfaces over a period of time, the infection is going to come back. So this is where we get to at this point. Threads have been removed, all porosity is removed, all rough surfaces have been removed. Now we have a shot at what the literature tells us. Hey, you can get bone regeneration with the causative factors removed. So we believed it, and we did it. So for 15 years, it's been successful. This step is EDTA being used to remove particles and debris, titanium dust, so forth. And as we go through the surgical procedures, our next steps are, this is just sterile saline being used again to clean that area. And we're going to put a layer here. We're going to use biologic growth factors going to be mixed in our bone graft, about 3 of them. 1 or 2 is good, 3 is better. You get a synergistic effect here. Now this is not in the literature, but this is what we do. And it's been working since we've been doing it, so I'm not going to stop now. We use M-Gain, GM21, and platelet-rich fibrin, 3 biologics in this bone graft. We call this our super graft, so to speak. That, I feel, is synergistic. Synergistic meaning 1 + 1 + 1 is 3, but if you got synergy, 1 + 1 + 1 is 6, not 3. And that is what we've been observing all these years from the results. So this would be an M-Gain biologic being placed over this area. As you know, M-Gain is responsible for bone regeneration and soft tissue attachment. This is our super graft with 3 biologics mixed in it already. Now this super graft is going to be covered with a collagen barrier membrane, as you'll see. So we've removed now the causative factors, no threads, no rough surfaces left. Biologics being used, bone graft is used now to regenerate what's been missing. And this is a collagen barrier now that we're placing to help stabilize and maintain this bone graft in position. And it's also saturated with a metronidazole intravenous liquid solution. So we're using a lot of factors here to make this go the way we want to see it go. And this is platelet-rich fibrin membrane that's been developed from a blood draw prior to the surgery starting. Now this is ready for us. This is full of leukocytes, which is anti-infective, and that's what we want. So now, since I've released this flap, we should be able to approximate that as tension-free as possible over this treated site. So as you can see, all goes well. We have regained our facial dimension, volume, and hopefully will regenerate an aesthetic result. They're using PTFE sutures here, Cytoplast brand from Osteogenics, of course. This is used to position this flap exactly back where it came from. And with the help of our biologics and growth promoting factors, we should be able to have this heal rapidly with no infection, no complications, no recession, and regenerate an aesthetic result. So once this is positioned with the PTFE sutures, then we'll close our vertical sutures with 6-0 osteogenics. So this is an early stage of healing in this stage. And we'll go on to the further end. So after 8 years, this patient is in my recall practice. That's how this case turned out. That's how it looks. So maintenance of aesthetics is possible with a combination of technique and biologics and materials. It's a pleasure to share our work with you, and so I've intentionally allowed time to answer questions and give you further details about the things that we have done, and I'm pleased to share. Thank you very much for that.
Great. Thank you, Dr. Wallace. We appreciate you sharing that with us. First question is, will you review the protocol? The steps of the protocol one last time, just to make sure? I think someone was taking notes, and they want to make sure they got the full protocol.
Protocol for our typical peri-implantitis treatment is number one, remove all threads and all rough surfaces. Number two, use of multiple biologics mixed in bone grafting. Number three, resorbable barriers, collagen preferably, positioned in place, and flap release so as to get full coverage without tension. So those are the biggies. If you manage to do that, you got it made. Now I might add to along that question, and there'll be some questions, I'm sure, so I'll answer it ahead of time. What instruments are used to treat implant surfaces so as to remove surfaces and to remove threads? You'll find out if in fact, attendees listening start to want to implement these practices. We teach courses to teach how to do this in detail, which takes a full day. However, one of the keys to make this work is we use surgical link burrs so as to access these areas under crown. You might not think about this, but accessibility is one of the main obstacles to getting this done. The reason for that is 99% of my colleagues, periodontists and oral surgeons combined, still adhere to the previous publications of the old adage of if you have 50% bone loss, implants coming out, replacing it. Most doctors do that, but we have a different philosophy, so we're here to tell you that you don't have to do that. That's not necessary. It's easier, but it's not necessary. So, next question.
Sure. Do you feel that there are complications associated with the titanium particles left behind after implantoplasty, even with the application of EDTA and sterile saline?
No, and I think that points out an oversight on my part. A step we didn't include in this brief sequence was the use of a pressure glycine spray. Hugh Freedy makes this, and that'll remove 100% of titanium particles. That's a good question. Correct.
Do you fixate the barrier membrane after placing the graft? It says, did you fixate the barrier membrane after placing the graft in the first case you showed?
No, we did not. We did not fixate this membrane. That was one of our early cases with anterior aesthetic type techniques. Should you fixate that? Not a bad idea. Surgical tacks could be used at the corners on the deepest part and fix that in position. Or if you have resorbable type materials that you can suture, nothing wrong with fixation. We just didn't particularly do it in that case. Would I do it again before? Usually I do fixation now with more than one implant involvement. One single case, probably not. If it's 2, 3, or more in the anterior maxilla, yes, I would fixate that with tacks. Correct.
Okay. Another question. You showed closing the flap with the cytoplast PTFE suture. Do you have any experience with the glycolon suture from Osteogenics, the resorbable suture?
Well, I'm a little bit biased because I think glycolon is the best suture I've ever used in my life. They're wonderful. This was an early case that we happened to use PTFE just so that it would stay put as long as we wanted it to. As years went by, we realized that we didn't have to do that, so we switched over to glycolon. Correct.
Can you just, let's see here. What is the fee associated with this procedure, and how long does the surgery take for you to do, and what is your scheduled time in the chair for something like this?
Yeah, well, those are good practical questions. When I started out with developing this procedure and found out it was going to be predictable and reliable, we calculated that if we would charge a fee for rescuing an implant that was equal to half the fee of placing a brand new implant. That was just kind of a rule of thumb. So we did it that way. Time-wise, they're not all the same. If you have to treat a second molar as opposed to number 10, not going to be the same at all, and it's not going to be the same fee. So we have a sliding scale based on difficulty and accessibility and time required. Typically, an hour and a half for an anterior site, posterior, 2 hours.
Great. A study that was recently published in the Journal of Periodontology, JPerio, about that actually described the negative factors associated with applying chlorhexidine to exposed implant surfaces. Is that something? It sounded like when I was listening, it sounded like that was something that you agreed with, and is there anything that you might have to add on to that?
Yeah, I would kind of go back to the previous slide that I had showed that a multitude of antimicrobial factors have been applied, Clorox, including chlorhexidine, multiple type things. Most of them don't do any harm, but they don't do any good either. It's a transitional temporary effect. And without removing the porosity in the threads, infection is going to return. So I might make a comment too along that line. Laser therapy is also a transitional. It's very popular, and there's lots of studies that show it's effective and different things occur, but we know from multiple studies that without removing the porosity in the threads, you're not going to get a long-term result because it's just a physical problem. Porosity harbors bacteria. You can temporarily get them removed. They're going to come back. So if you don't do something physically to change, and the research bears this out, you have a return. So We don't want to get on a merry-go-round. We want to fix it one time and be done.
Great. Do you routinely remove the crown off the implant while everything is healing?
If it's possible, that is really a nice thing to do. You know, when you treat as many cases as I have, you get kind of spoiled. And so I treat my doctors who remove crowns for me a lot nicer than the ones that won't. No, we don't discriminate about that. Typically, if a crown is relatively easy removable, by that I mean if it's a tight implant system that we use and it's a screw retained as opposed to cemented, pretty simple and straightforward just to get to the access, take that off, treat it, and put it back right the same day. Now, I think the question I think where this question is leading is, how long does it take to get this ready to go to put the implant back on, put the crown back on the implant? A lot of my colleagues, some that I'm acquainted with, will submerge implants in order to get them to regenerate because they have not removed the rough surface or the threads. So they'll submerge them for 6 months in an attempt to force the soft tissue and bone to regenerate. And to some degree, I'm sure that works. However, 6 months waiting time for crown replacement is not very practical. Therefore, we don't do that. If I remove a crown, I put it right back on at the end of the surgery. No reason not to. If it's not removed, then it's there when we start, and it's there when we finish, and it gets well and it heals just the same. So, removal of the crowns is nice and desirable, but not necessary.
Okay, great. This is a good one. Do there have to be any bony walls present for this to work? Also, how do you access the threads on the palatal or lingual aspects of the surgical area?
With a lot of practice, that's how you access them. There again, good question. I'm not making fun at all, but I've faced this problem many times, so I'm very familiar with that difficulty. Thread accessibility, for example, number 2 or number 3, number 14, number 15, palatal threads, that's where the specialized burrs that we use are surgical length friction grip burrs, and the handpiece is a small head pedo. That's the key. Friction grip long shank burrs, pedo handpiece. That's how you get accessibility to these difficult places. I think that was the second part. I forgot the first part of your question.
Do there have to be any bony walls present for this?
Oh yeah, bony walls. Right. Well, no, they don't have to be. I mean, it's a huge bonus if there are, and I would say in the cases that we see and treat, 90% of them have bony walls. Most of the time, these are particularly around molars and anteriors too. It's like a concavity. Infection produces a concavity kind of effect. So you do have some bony walls, but typically you can get 5 to 6 millimeters of vertical bone regeneration. If you have bony walls, it's quicker. If not, you can still do it. Now, many times, if you have an advanced case and no bony walls to help you, and you need to gain some vertical really badly, you can turn to use of PTFE membranes made by Biohorizons, not Biohorizons, but Osteogenics, of course, and that will maximize vertical bone regeneration. That will help.
Great. Along those same lines, question came in. What if you have an implant that has a bridge on it, and basically I think they're talking about multiple implants or at least 2 implants. It has a fixed bridge with vertical bone loss across the entire portion. How would you modify the treatment?
Yeah, good point. Well, that's another case. Most of my colleagues that do these kind of cases, if they have a bridge with implants that are defected, they take everything out and start over. That's how they do it. That's simpler. However, that's not absolutely necessary. With the bridge work, take example from, say, number 3 to number 5, 4, you can have the bridge removed by the restoring doctor. And if you can do that, then implant reconstruction and bone graft vertically is much simpler. Now, you can do it with a bridge in place, but the magnitude of difficulty is like 3 times greater. You can still do it, but it's gonna cost you. It's gonna take a lot of time and a lot of work. It can still be done. See, I think 90% of the effect is getting rid of the threads and the rough surfaces. In my opinion, and the way we practice, vertical bone regeneration is like icing on the cake. The more you get, the better we like it. Do you absolutely have to have it? No. You can get things stabilized and keep the level of bone exactly where it is. And if it doesn't progress, you still won't lose the implants, nor the restorations, nor the bridge work. So that's a long way of saying it can be done without the bridge taken off. It's going to work out better for you if you can get it removed.
Great. Another 2 good ones. Did you ever need to perform simultaneous soft tissue grafting in these cases?
Oh yeah, all the time. Of course, as a periodontist, naturally we have our eyes open for the lack of soft tissue grafting. And I didn't have time to present the research, but it's been shown that Peri-Implantitis resistance is maximized around implants with a 4 millimeter thickness of keratinized soft tissue. Linkevicius in Eastern Europe has shown these results many times. He's a well-known researcher. So that's the key, 4 millimeters. So if you've got an implant placed, particularly in the maxilla, anterior, aesthetic zone, if we see very thin or no keratinized tissue present, yes, we will simultaneously augment that probably with connective tissue grafting and or an acellular dermis type material, depending on the critical aesthetics that we face.
What type of, you've mentioned it, but mention again, what type of burr do you use to remove the threads, and how do you keep the implant from getting too hot?
Yeah, that's a natural question. Dentists we're all mechanics, so we're thinking about those kind of things all the time. Well, number one, the heat issue. Implants don't get hot. You use water hand pieces with water spray. That doesn't occur. Otherwise, accessibility is required to have surgical length burrs with small pedo head hand pieces. That allows you to reach the areas. You know, there's a little kit called a Wallace kit that we used to use for some time ago. Anyway, they still make it, and that has a number of burrs that we use that are different sizes. And I'll just digress about this for a minute, but the principle is you go from large to small, particularly with thread prep, removing rough surfaces. You use the biggest threads, implant burr that you can get to begin the process of removing the gross prep threads. Then you go down to the smaller size, diameter, and length burrs to finish the job and get in a proximal, go around the implants. Typically I'm digressing, but I'm going to do it anyway because you asked me. Typically, our technique is to access and prep one side, which is most accessible first. For example, we have number 30 implant. We'll start with facial flap reflection for number 30, and we'll prep the facial, the mesial, the distal, and with small burrs that we use, when we get down to that level, we can go around that implant and prep part of the lingual on the mesial and the distal, so that when time comes to access the lingual, which is more difficult, we don't have as big a job. So we've done most of the work from the facial, and then we finish up a small job on the lingual. That's just a real world technique solution to how that's done. That's what you're asking me.
What is the post-op care instructions that you give to the patients after the procedure?
Yeah, that's very critical. That's very critical. Patients, as usual, any surgical procedure, they're afraid to resume normal care. So we give it to them in writing and emphasize to them, personally, face to face, of course, that this area that we treated surgically, number one, the glycolino sutures that we use will be resorbed in about 6 weeks. For the first 2 weeks, we just tell them not to do anything interproximally, because that could adversely affect your bone grafts, your soft tissue flap adaptation. So for a couple of weeks, we just recommend don't touch it. Just stay away from it. Then, of course, we see them at 2 weeks for a post-op, and at that 2-week post-op, then we say, okay, now's the time. We want you to start going interproximally with very small brushes by hand. No water pick. That's death. Water pick is death on Peri-Implantitis treatment. So you make sure that you don't let them do that. No electric toothbrushes. All this is by hand. When you get to the 6 weeks point, it's everything normal. Interproximal normal, brushes, electric, still no water picks are the most dangerous thing they can do. So that's our typical protocol. We do have one advantage in that I went to pharmacy school back in the old days, so I know how to make things. We make a specific metronidazole antibiotic gel, 1% metronidazole, which is a broad spectrum antibiotic for pathogenic bacteria. And we put our patients on this antibiotic gel for the 2 weeks that we tell them don't touch anything. So that prevents any exposure. In addition, we do prescribe oral antibiotics starting a day before their surgery and extending 4 days afterward. Without any antibiotic sensitivity issues, we'll go to Keflex. If that's not permissible, then we could step down, we go to the Mycins or other antibiotics that don't have penicillin allergy issues. So that's a long answer. I'll apologize for all the detail.
Good. What type of graft material do you use? Is it an allograft that you're mixing with the growth factors? And is it a 100% cortical allograft, or is it a mixture of cortical cancellous? Can you just talk about the graft material?
Yeah, great question. Yeah, for many years we've used Mineros cortico cancellous bone graft. And that's exactly what this you saw used in the video. And that's what we use for every case.
Okay, great. And one more time, it just came in, but just repeat the 3 biologics, if you don't mind. I think that is a key takeaway, but the 3 biologics that you're using there.
Yeah, you're right. I think the biologics are the key to vertical bone regeneration. Without the stimulation of the biologics, I seriously doubt we would be getting the type of vertical bone regeneration that we see. Just to digress just for a little bit about that, in the literature and the reports that we see in years past and recent publications, you'll see 1.5 to 2.5 to 3 millimeter vertical bone regeneration at the maximum, and that's in very small cases, numbers of cases. In our practice, we routinely can achieve 4, 5, 6 millimeters of vertical bone generation. So the question was, what biologics are being used? Well, platelet-derived growth factor is probably the most potent one, which is GEM21. GEM21 it contains probably 100 times the growth factors than plain blood plasma. Number 2 is imdogaine. That's being used to promote reattachment and some bony deposition. And third was platelet-rich fibrin, PRF, which is derived from, of course, a blood draw. Those 3 are the big keys to vertical bone regeneration.
Got you. Just a couple more. I got time for a couple more here. The burr, do you use a carbide or diamond burr for the thread removal?
It's a combination. That we use two types of carbides. There's the elongated, kind of like a candlestick shaped carbides that are fine and then coarse. Then we have kind of a barrel shaped round burr, also fine and coarse. And as we move on down the line, it goes to like about a number 4, number 2 carbide. All these are surgical length. And then lastly, there's number 2 type burr that's diamond. So it's a mixture of shapes and surfaces, carbides and diamonds.
Gotcha. You showed, let's see, last question, or well, maybe last question. Let's see. You showed using a collagen membrane there for the case that was in the video. Would you ever use a PTFE membrane in this case? Or if not, when would you use a PTFE membrane? For example, in vertical ridge augmentation cases, would you use one?
Yeah, that's a good point. Yeah, PTFE membranes are very, very good at excluding soft tissue ingrowth. And if you can exclude soft tissue ingrowth into your grafts, you're going to get a better result. So cases where I would choose a PTFE are advanced or severe, or bigger, deeper cases where I've got a lot of bone regeneration. It's deep and wide. It's just a degree of severity. So the severity of the defect dictates choosing PTFE.
Great. Do you have any experience with BMP2? And if so, does it have a place in these type of protocols?
Good point. Yeah, we started out as I was fine-tuning my technique 10, 15 years ago, well, 12 years ago. We use this BMP material. Its brand name is Infuse. Infuse is used in back surgery, spine surgery, fusions, that type of thing. And it's the most potent biologic that there is. However, you have to figure in a cost factor. And so we used Infuse in lots of cases for a long time, with the cost factor notwithstanding, because I wanted to see what it would do to help us. And so we gradually migrated away from Infuse as we found replacement biologics would give us just about equivalent results. So is there a place for BMP? Yes. Infuse, it'll cost you, but there's ways to use that in bigger cases and make it cost effective. But it's when I say don't use it, absolutely not. That's great if you can justify the cost factor. However, we have found that we don't seem to suffer from not using it any further.
I'm not familiar with this question, but I'll ask it, and hopefully you are. What G-force are you using for PRF?
Well, I don't think I can answer that question either, because I have delegated that to my chairside surgical assistant, and she knows everything about that, and I know basically nothing except how to use it. I will say this though, we do use Rick Myron's horizontal centrifuge with their typical protocol, so I can pass that on to you.
Great. Okay. I think we got a ton of questions, and we actually got through all of them, so that's great. So with that, Dr. Wallace, appreciate your time again. Thank you for spending time with us this evening. Thank you for sharing information based on your experience in the literature and your protocol. I appreciate everybody that logged on that was able to join us tonight. We always enjoy hosting these webinars, and we hope that you enjoyed it as well. And with that, I will tell the audience good night and have a great evening, great morning, great afternoon, depending on where you are in the world. Thank you very much. Bye-bye.
Great to be with you. Bye-bye.